So with that, without any further ado, I want to introduce Katrina Kubicek from the University of Southern California, who is right here. Great. Introduce our first panel.
My name is Katrina Kubicek. I am the Associate Director of the Community Engagement Program at the University of Southern California Clinical and Translational Science Institute, and I'm really excited to be a part of this symposium today. You'll hear more from me in the afternoon, where I will be highlighting one of the projects that our team has taken on, so I'm not going to talk a lot about myself right now, but I will say that I'm really honored to be able to introduce and moderate this first panel, which I think represent three really exemplary groups of partnered research with academic and community partners and represented from three different CTSA organizations. So at this time, I'd like to ask the panelists from the first group to come up, and then I'll introduce each of you separately. We have John Brekke and Laura Pancake, Aubyn, Stahmer and Karyn, and Tumaini and Christine Park. Y'all can come up, and then I'll give a brief introduction for each of you. How you doing? You made it. So the way this first panel is going to work, each group will have about 20 minutes to present on their particular studies, and that will give us enough time afterwards for some questions from the audience for each of the speakers. So I'm going to hold off on questions until the end, and there will be microphones placed out in the audience for people to ask questions. Bios for all the speakers are in your booklet, so I'm not going to waste precious time reading what you can read. So I am going to introduce briefly the three groups. The first presentation will be with Dr. John Brekke and Laura Pancake. They are representative of the CTSI at my institute, and we're going to be talking on a project they've been working on for the past several years. And then we will have Aubyn, Stahmer and Karyn from UC Davis, CTSA. And then finally, we will have Tumaini and Christine Park from UCLA. And I think it's a good mix of presentations of different topic areas and hopefully give you some food for thought. So without further ado, I'm going to ask John and Laura to start us off. Okay.
There we go. I can use this as well. Right? Great. Good morning, everyone. My name is John Brekke. This is Laura Pancake here. Laura and I have actually worked together for, as I get older, the years, I kind of compress these time frames. I think 15 or 20 years, yeah. And when we first started working together, I was kind of doing the more traditional model of research, at least in mental health, where I would go to an agency and pitch an idea. And it was usually an idea for a project that was going to gather data about a particular population of individuals, usually with serious mental illness. And I would try to convince them that this research was going to have some impact on them and on the world. And I was usually fairly confident that the research I was going to do might have some impact on the world if things worked out well, but I really couldn't be too convincing that it was going to have any direct impact on them, although I tried as best I could. And thank goodness Laura and her group at Pacific Clinics and prior to that at Portals Mental Health Agency were very welcoming to this research. I was basically asking them to be a good host for our recruitment. And then over the years, we evolved into things that were much more partnered. And recently, we built a psychosocial intervention together and are testing it together now in a PCORI-funded trial. But today, we're going to talk about, want to talk to you about another partnered project that we call the Recovery-Oriented Care Collaborative, which is a practice-based research network. Now, I didn't know a whole lot about practice-based research networks until about 5 years ago when Matt Meyer pulled a bunch of community folks together and said, hey, why don't we come together and start asking questions that we want to ask as practitioners? And let's partner with someone who does research so they can help us create protocols where we're going to get meaningful answers. And so that's where the Recovery-Oriented Care Collaborative came from. And as some of you may know, there's this 15-year gap. Sometimes people say 12 years, sometimes people say 17. But there's a gap between the publication of scientific findings and their impact on usual care. I think that's a commonly stated kind of issue. And of course, this is a problem for practitioners because they don't get to benefit from the newest research that goes on and the newest findings. And it's a problem for researchers because we don't see the impact that we would like to see in terms of what goes on in usual care practices. So these practice-based research networks are one solution to closing this gap. Are any of you here involved in a practice-based research network by any chance? I'm not surprised. You know, I was at a recent meeting of the Institute of Medicine, and I was on a panel with a fellow from a medical school, and I said, so I'm working on a PBRN. Are these things really real in primary care? I read about them all the time. He said, he was from the University of Colorado Medical School. He said, yes, they're not only real, but they're the backbone of the research in numerous medical schools. And so I began to believe that this idea could have some reality. Now, in mental health, they're not very common. But a practice-based research network is a group of care providers that come together around issues and questions that impact their practice. And they partner with researchers to answer them. And then there's an immediate impact on service delivery. So providers generate and vet the study ideas. We academic folks assist in the logistics over multiple projects. Now, these were actually started in the 70s within primary care. And by 2014, there were 154 of these registered PBRNs across 44 states in the US, which is really a remarkable accomplishment. Now, few of these PBRNs consider any mental health issues, and only a handful of them include mental health providers. So we decided to create the Recovery-Oriented Care Collaborative here in Los Angeles. A group of originally 4 mental health agencies came together. 4 of the largest providers of mental health services came together and decided to try to form one of these. The goals of this ROC are to identify questions that center on the practitioner's experience. This is crucial. Laura will talk in a moment about how we actually did this to create questions that center on practitioner's experience. And the goal is to actively include practitioners in developing a research protocol, collecting and analyzing data, and disseminating and implementing the findings. So when I say practitioner, I mean administrators, frontline service delivery individuals, consumers of mental health services are all involved in this activity. And there's the expectation of continued collaboration rather than a single project. So these are set up with the idea that we're going to be doing things together for a while. And of course, one of the ways to bridge that gap between practice and research is to have practitioners and researchers talking together, thinking together, eating together, figuring out what data to gather together. And that's what this turned out to be. Laura and I do this a lot together, and we always try to figure out who's going to say what when. So I think, okay.
Okay, good morning, everyone. I've been incredibly fortunate. John's in denial. It's been over 20 years, I think, working with John, and I was spoiled for a long time because I thought that's how all researchers worked, that they came in and were really nice and said, what do you need? How can we help you? And then through experience, I found out that wasn't always the way it worked. But John, even prior to these projects, he always worked in a very collaborative way. and finding out what would work not just with our staff and for our consumers, but within our system. And so I think that's a really important piece. So as we moved into kind of this next step of the ROC, that was on the forefront of it's got to be something that's incredibly relevant to our staff and our consumers, but also will work within Medi-Cal billing. And if anyone's going to do any research in mental health and public mental health, that has to be the number one priority, is that it has to be something that accommodates that, because all 4 agencies' finances are driven by that system. So the first thing we did was create a ROC steering committee. There were people, leaders like myself, I'm a corporate director at Pacific Clinics, and we came together, and we had all worked together for a long time. 3 of the agencies actually now, I've worked with for over 20 years. We knew each other well. So that helped because there were a lot of nuances that we could kind of get out of the way, and we knew the priorities and the focus of each agency. We didn't have to become familiar with each other. We also, all of us believed in using empirical information to guide our decision making, and we were willing to deal with disconfirming findings. That was a little scary, but we were all kind of the same mindset. We're progressive agencies. We like to try new things. We like to challenge ourselves and our staff, so we were kind of all on the same page in that sense. And then we all agreed to dedicate staff and consumers to work on the PBRN. And then, very importantly, again, we gave relief from billing requirements for participation. If you're going to go into a mental health agency and do research, this has to be a factor. People have very high productivity rates for Medi-Cal. I know this isn't the most fascinating topic, but it's a reality of doing business. And so for people to be engaged and supportive of the research, you have to take that into consideration and give them a break on their requirements, which is what we all agreed to do. So as John had said before, we all had mutual respect for each other, and I mentioned that as well. And then the original leader, Matt Meyer, was a respected agency leader who was incredibly enthusiastic, had done his homework. And so it was interesting when he came to us with this, we didn't even hesitate for a second because we knew him and we respected him. And then having John on board was, you know, piece of cake. Everybody was going to be on board with anything that he was going to do, which helped. And again, the reason for that is because he had been so collaborative for so many years, and we knew that he would be easy to work with and have our best interests, and knew our agencies and our consumers really well, and what would work well with them. So we convened 3 day-long meetings. It was pretty time intensive. It's a big commitment. I think we were a little nervous about that in the beginning. I know I was. We're all over LA County. Travel time alone, you know, is an issue. But we all agreed to do it. And our staff, surprisingly, even before we mentioned they would get a break on their billing, agreed to do that. And I've seen that over the years, but staff really do want to be involved in research. They do. And so they were very enthusiastic. So we convened these 3 day-long meetings. We introduced the practice-based research network, and we wanted to generate and vet practitioner and client questions for research. So we worked with an academic team to create research questions and a card instrument. I'm sure you're familiar with a card study, just very brief questions, 5 or 7 questions, can be administered in 5 or 10 minutes, which also helps. We've been approached with assessments that are 27 pages long for our staff to do. Not always welcomed. And then we implemented the study with practitioners, recruiters, and data gatherers. So our actual frontline staff did the gathering of the data. Okay, so this looks a little complicated. I'll kind of go through it briefly. I'm going to touch on some details, though, because I think it's important and an interesting process that we went through. So this is the reflective practitioner process model for study topic selection and study design. So first, the ROC members were all polled from 4 participating agencies. We went to this all-day forum, and everyone was polled about questions, and they identified 99 potential research questions that were then categorized into 23 domains by postdoc fellows. The 10 domains were then, with the most perceived interest, were selected for presentation to the full ROC membership. This process was incredibly empowering for staff, and many of the staff who were there were people with lived experience. They were peer providers, so they had mental illness, and all 4 agencies prioritize hiring people with lived experience. We have a lot of staff that have mental illness themselves, and so they were part of this process. And it was empowering for all staff, but particularly for those staff. Some of them had not been involved in research from that perspective before. They had been the subjects and not developing the questions. So that was really fantastic. So at a second all-day forum, the 10 domains were discussed and refined into researchable questions. And then identified questions were evaluated based on criteria developed by Knox and Lamonico. Am I saying it right? Lamonico. So the criteria are over here, and John made it very tiny, but I thought it should be its own slide because I think it's really interesting. These were things that I think staff had not been asked before, which is, will it change my practice? Will it change my colleagues' practices? Is it feasible? Is it publishable, of course? Is it fundable, most important? And is there a provider champion? Is there someone that's going to lead this and be interested, and it's going to drive this process? So these scores were tallied for a composite score for each question. The 4 highest scoring questions went to the next step, which is that the postdoc fellows performed literature reviews for those questions, and they wrote background summaries and a sample card study for each research. And then they sent it out to all of us. So it narrowed down to 4 card studies. Sent it to us, and then we all voted via email. So that piece was very efficient and not time-consuming in the least. Some members were upset that their question that they were very passionate about did not make it to this process. So I know with my agency, I had to have some discussions and talk around that. But in the end, everyone was very satisfied with the question that was selected. And John's going to go over that question in a minute. And so after we obtained IRB approval, our staff began collecting data at the sites. I know that my staff collected it with consumers that she had not worked with, so that they, of course, they were doing it, anonymously, but she did not have any influence over them or had not known them before, which was nice. And then the research team analyzed the data and presented the findings to the ROC locally and nationally. And now John's going to share those findings with you.
So after all of that process, which really was amazingly, it really was quite empowering for the providers and the consumers to be involved in this very different way in research. They ended up wanting to ask this question about their integrated care services. Integrating health and mental health services has become a very prominent issue nationally and locally. So the question was, what's the impact of our integrated mental health and healthcare services on access to healthcare, utilization of healthcare, and health and mental health outcomes? So we ended up gathering data on 237 participants from 4 of the clinics involved. I'll go through these results fairly quickly in the interest of time. But what we did is we asked these consumers, who were all in one of 4 different integrated care programs. For example, the question for the consumers was, consumer and patient is the same thing. In mental health, we call them consumers. In other settings, they're called patients. But we would ask them, since you began this integrated care program, have you been going to the emergency room less, about the same, or more than before? And that's how each of these questions was structured. And you can see that a vast majority were going to the emergency room less than before. This is one of the goals of the integrated care program. Changes in primary care service use was not as dramatic because 2 of the agencies were doing mobile teams. 2 of the agencies were doing connections to outpatient primary care. So the change in primary care service use wasn't as dramatic. But the change in healthcare access was dramatic for individuals in these programs, as well as their change in their own physical health. All of these results are statistically significant, by the way. But changes in physical health care, changes in mental health, changes in lifestyle, all of these things were markedly improved, at least from the perspective of the consumers who were participating in these programs. Now, just to go back to this one for a moment, this is one of these things where when you're asking consumers to evaluate their experiences, you're always looking for a pattern. And we were glad to see that we didn't see as dramatic a change in this item, because that meant to us that these consumers are actually reporting quite accurately, because some of these agencies were using mobile care services rather than trying to link them to outpatient care. So just want to briefly mention a couple of challenges that we encountered in doing this recovery-oriented care collaborative. Time. Time is a huge issue for practitioners. It's also a big issue for researchers. Yep, got it. So developing the research question, refining the card study took several months. There were frequent delays in the process, IRB approvals that went on, revising the study instrument, pilot testing. All of this is familiar to us academic researchers. Our folks in the community were saying, come on, we make decisions, we make things happen. Why is it taking so long to get this pilot testing done? Why is the IRB taking so long? We're ready to go. On the other hand, the time required to involve agency members in the development of research question was a challenge for the researchers. We're used to doing this on our own. We're not used to having a vote. So we had some challenges to work through. Now, using agency providers to administer the surveys had benefits and challenges. It would horrify an NIMH review panel. On the other hand, we had a fabulous response rate because these consumers were known, the administrators of the surveys were known to the consumers. Well, we have dissemination of the findings and sustainability. We have disseminated these findings to staff and clients. Very, very wonderful experience to have, actually, to show folks how their services are impacting the world. They were delivered to the agencies and their stakeholders, Department of Mental Health. We went to a national PBRN conference, wrote a white paper. We have one publication in press now and another under review. PBRNs grow. We want them to grow. We have a new mental health provider who has joined our PBRN. And we're also preparing a funding request, because PBRNs move from these very kind of rudimentary kinds of projects, which is where we start, and then hopefully one day we'll get an RCT funded to look at some of these different models of care and how they impact stuff. So the next thing we're going to do is a PBRN project where we're looking at what are the most critical components of services from the perspectives of consumers and practitioners. This is something that was critical to both the consumers and the providers. And if you're interested in reading a little bit more about this, this might be available online now, I'm not sure, but this is a piece in Psychiatric Services that describes this a new mental health PBRN that we're all actually very excited about and having a good time with. So thank you.
I'll get this up for you. Okay, so next we have Karyn and Aubyn Stahmer, who will be presenting on the Southern California Bridge Collaborative.
Hi, everybody. I am now at UC Davis, but this is a San Diego project because I've only been in Davis for 2 months. So I just wanted to acknowledge the UCSD component before we get started, but we're very excited to be able to talk about the Bridge Collaborative. We've been collaborating around early intervention for very young children at risk for autism. Did we say 2006? Good. So we'll talk about the collaborative, but I'm going to let you start because it's Karyn's fault we're collaborating.
And it's Aubyn's fault that I'm here. And I know nothing about research that I haven't learned from her. I started a clinic in 2003 after the explosion of the diagnosis of children with autism. And what I started feeling in 2005, where there were so many of the families coming to me with younger siblings and they couldn't get services for them. I'm a speech and language therapist, and I've been working with children with autism since the late 70s. That's how old I am. The families were really, really desperate to get the young children taken care of. And my focus was always on parent-child interaction. So if the parents were anxious about the development of their children because they had an older sibling with a diagnosis, that younger sibling was going to be impacted by the parents' fear. I was unable to get funding from any place. I'm a private practice, or what we like to call negative profit practice. And I started a pilot project. I know nothing about research. I know I've read pilot studies, so I thought what I'd do is just provide free therapy for families of these children and start collecting data. Again, I'm a therapist. I know nothing about collecting data. I can barely read research articles. But I knew Aubyn from another event, from other volunteer places that we would meet up, and she seemed very approachable, and I thought I had a brilliant project. I was working with 4 parent-child dyads, children under the age of 2, and I was doing play-based, hand-over-hand, modified signs and gestures, and I really started developing a program. We videotaped everything, and I brought it all to Aubyn, and I thought, wow, this is just it. She's going to take my program, and she's going to collect data on it, and it'll be exactly the way I had set it out. So fast forward, how many years later are we? It's now 2015. We have the Bridge Collaborative. We have a program that we are using with this population of children, but it has very little resemblance to what I came to her with, but I love the project. And I should have been using the overheads, but so we were seeing that the children were getting more children who were at risk for autism, and there was a limited research of evidence-based practices. And that's one of the things that was really concerning too, because there's all this focus on evidence-based, but what kind of evidence base is there available for very, very young children and their parents? And what was very exciting to me was to find out that researchers can work directly with community clinicians and make a change in the way we're doing things. So the partners in our group, and I probably should let you take this over at this point, yes. Aubyn, instead of saying, yes, Karyn, we'll just work with your work, invited a lot of other people to join us. Occupational therapists, doctors, speech and language therapists, behavioral specialists, educational specialists, and infant mental health specialists. Those were the community partners. We had a research team, which was people who had been doing research in autism and community-based, you see, that's the part I can't, community-based participatory research. Funding agencies, because as you said, that's very important, particularly in small private practices like mine. So we had to get support from Part C funders and private insurance. Of course, they don't really look at what we're doing, but as long as we can get the data to them, they'll fund some of the time. And then we really wanted to make sure that what we were looking for and what we were developing was going to be a good fit for the families. We wanted to have families who had ASD early start experience, so our first people that we reached out to in the community were parents who had been through the early start process, but now could look back and reflect on what that process had been for them and what they might have wanted. And we wanted to make sure that it was multicultural. And then we formed the Bridge Collaborative.
You're done.
I'm done.
No, you're not.
I can answer some questions.
She'll pipe up, don't you worry. So it took a long time to form this name, as I'm sure many of you also do. But we wanted to look at the bridge between parent and child, as well as the bridge between research and practice. And then we made up some great, we made up some words. We picked some words also that would go with that met with everybody's sort of view of what the intervention should be. And so what our goal was to think about what critical elements of care for kids that young would be based on the research, what providers were already doing or felt was critical in their practice, what the families thought was important, and try to find something that went together to pick an intervention or develop an intervention. We started with develop an intervention to maximize what was acceptable and effective.
We were supposed to develop mine.
Oh, right, your intervention. And it was a great intervention. So we started looking for funding, and there happened to be some NIH funding for collaborative building, and so we developed as part of that a leadership structure that involved a coordinating committee of 13 members representing all those people that Karyn just talked about, an operations group that consisted of our key community partner, Karyn, myself, and one of the parent team members, because the grant agency really likes to make sure everything gets done. And then a collaborative process committee, actually led by Dr. Lauren Brookman-Frazee, who is here, to make sure we were collaborating well and not just meeting together and bossing each other around. And then also separate work groups. So different collaborative members, sometimes a community member, sometimes a research member, would lead work groups based on what our current needs of our group were. So we started completely unfunded, meeting once a month, and I'm glad you said eating together, because that's one of our main functions that seems to really help everybody come to the meetings. And then once we got this R21, we were able to develop this more clear structure and a plan for what we were going to do. We also brought in consultants anytime we didn't know enough about what we were talking about, and that was really helpful as well. So year 1 was unfunded. Years 2 through 4, we had an R21, and I'll talk about the process we used to get to our intervention. Then we didn't have any money again, so we were madly writing grants, and then we got 2 at once, which is great and a little terrifying, and so we're working on those right now. And so I'll talk a little bit about our process of figuring out what we wanted to do as a community to help this. We all agreed that these young kids, 12 to 24 months, who were showing signs of autism needed more service in our community, and figuring out what to do about it. So first, we wanted to choose a method of capacity building. We thought we needed early intervention. We wanted it to be parent implemented because of that parent-child relationship. That was both important for the community members and based in the research. We wanted it to be relatively brief so that parents could get more intensive intervention if it was needed, and so it could be funded. Of course, we wanted it to be evidence-based, and we wanted it to have broad appeal because in autism, there are 2 sort of camps of early intervention, and we wanted to make sure everybody agreed, relationship-based and behavioral. So we did a lot of lit review, research team members presented on different literature, and then community members also presented on what they were using in the community so we could look for those areas of agreement. I'm going to go through this rather quickly because the process is more important than what we did. Then we brought in our top 3 choices for interventions. We had the intervention developers come, do a half-day conference, and around that, we did conference evaluations, and we also had a set of 10 providers and 10 parents that weren't part of our group come to each of those conferences and do focus groups with us afterward. And then we had a nice long half-day meeting with the intervention developer to see if we liked them and how much they'd be willing to let us screw around with their intervention. And then we made the final choice, and the final choice was important process because we had people were coming together learning more about sort of each other's views, which was nice, but people still had pretty strong feelings about which of these 3 interventions they wanted. So we were concerned that no matter which one we chose, we would sort of lose some of our members, which was not kind of like you guys were talking about. People had, were upset if theirs wasn't the one. So we brought in an outside facilitator to help us, which I thought was a great process. Did you? Yeah. She did this really great consensus building and had us do things that did not seem argumentative, where I think everybody felt like their opinions were heard, and then we did not lose any members when we came to the choice, even though some people, it was not their top choice. All right, so then we did this adaptation and pilot study where we trained 10 local therapists and followed about 13 families using a single subject design to determine the feasibility, satisfaction, and outcomes. And I'll talk about that in a little bit. But we also measured partnership synergy, which may be the important thing for you guys. Over the course of the first 4 years is where I have data, and we would do this 46-question survey developed from the literature about once a year. where we looked at satisfaction, trust, research team, decision-making, impact, and structure on a 1 through 5 rating. And you can see that we had a pretty good team right from the beginning in terms of trust, in terms of satisfaction. And when you look at decision-making, impact, and structure, satisfaction with that improved significantly from year 1 to year 4. Of course, impact, we didn't have much when we started, but by year 4, we were actually implementing intervention in the community and felt pretty good about that. It's funded by our Part C, and people like the structure and decision-making process a lot, which is nice. We also have good sustainability with people still showing up for meetings. We probably need to do this again now, but we still have pretty good participation. 86% of initial members are active this year. 90% of agencies, we had one agency not be able to continue because of funding, but everybody else is still there. Our intervention is funded by Part C and some insurance companies, which has been a huge benefit. And we've been able to get external funding. We have tons of products, which I won't go through, but we have lots of articles. We give presentations a lot. Karyn loves to sign up for conferences to give presentations at. Yeah. We have developed a toddler manual version with the program developers that is probably going to be published pretty soon through a community press. And we just finished a web-based training program for providers that will be out at the end of this month, so we're very excited about that. So our current project has been to adapt the manual and the training materials and a sustainable method of training, which is one of the reasons we chose this intervention. So we're training agency trainers to train clinicians at their own agencies so that when the research team is gone, there are key partners there. It's challenging still to find the community partners. We'll offer the training for free, but the community partners need to give the time, and that's been a challenge. And then we'll look at child and family outcomes after that. So we think that we have learned lessons that we are pretty productive, and collaboration can be measured. We like that part a lot. We have a lot of collaborative process talk at the beginning of every meeting, which often is around what's going on in the community. So people like to come to the meetings. In the beginning, there was a lot of concern about we're in competition, but now I don't think do you think it feels that way at all anymore? 15, I think. So we've added a couple people from different places. We have a great new physician from our Part C agency who's been advocating for us at every Part C meeting, which has been great. It does take a lot of time and commitment, like you guys talked about. I don't think that can be understated. We've had many years of unfunded programming, and so people come to those meetings only for the bagels and the company to keep things going.
The funding for the individual agencies is huge.
Yeah, so the funding for the actual training. So the grant, because it's an implementation process grant, they want the agencies to do their own intervention and training. So we can provide the training. We can provide funding for the collaborative members to come to the meetings at some agencies. At other agencies, we can't. The agency provides the time. So then it takes educating new agency leaders. We try to provide equipment and materials instead, but that's an issue. And we try to share our research assistance for different projects. We found that joint learning to build trust was really important, especially in the beginning. Having everybody do presentations about what they were doing, what was important to them, and learning from each other was really, really important in the beginning. We have had people really change their vision of what other therapies are like that they didn't trust before, which is really nice. And I think in our community, in our early intervention community, speaking in a more unified way about what kids should get, which I think is helpful for families. Having specific tasks is really important, so continuing just to kind of meet randomly is not that helpful. People get tired of coming, so we're really careful to have tasks, which we have plenty of right now. Really clear expectations, so our community providers are short on time, and so making sure that the research grants do the infrastructure part is very helpful as well. Also, our reports from our collaborative process is that having a clear leadership structure is really helpful. So in the beginning, we were trying to be sort of rotate leadership of meetings and be super duper collaborative in every way. And our community partners are like, look, we don't have time to be building agendas and buying bagels. Can you just do that part? We can come to the meeting and bring ourselves and what we need to bring. And so the research infrastructure is very helpful for that piece. So everybody gets to contribute to the agenda if they want to, and hopefully feels that they can say anything they want, but the research team sort of keeps that infrastructure going to help that process. Flexibility is really important for everyone. Like you guys were talking about, things are slow in the research world, and research designs like randomized trials are not so great for community agencies who have to provide service. It's not like they can randomly assign kids. That's not what the government really likes to see. And so coming up with designs that work has been important. Some challenges, we've talked about the funding, the research designs, keeping the momentum going, getting new grants is helpful for that, and sort of new ideas of where to go. The consensus building, really, really, really important. I highly recommend having somebody who knows how to do that is not part of the group do it. Great community buy-in for our project. We now have funding for the service, which is really wonderful. We think we're improving quality of care in our community. And increasing the sustainability of the practice because we've worked together to develop a training model. We'll know more after we take more data. We also have a really great research infrastructure. So when we have other collaborative processes we want to think about, we have partners we can go to where we can recruit kids, and I don't know, how many collaborative boards are you on? A lot. And it's really great as a researcher to have that sort of infrastructure. And we've built community collaboration beyond just the project that we're working on. So here's our team. If you need more info, and we will be available for questions. Oh, I knew you.
I think one thing that Aubyn underplays is the importance of her role in getting this all started and sustaining it, because she has such a collaborative sense that even if somebody is proposing something that is way out there and not really in line with our vision, she's able to listen to that input and reframe it. And without her leadership, this never would have progressed as far as this has.
Thank you very much.
Okay, so the last presentation for this panel will be with Drs. Tumaini and Christine Park from representing a project at UCLA and Northeast Valley. Is that correct? Okay, come on.
Good morning. I'm Christine Park, and I'm the Pediatric Medical Director for Northeast Valley Health Corporation. So the project that we are working on with UCLA is called Telehealth Collaborative Care, and it's a partner research case study. Our original goal when we put this project together was to work on improving access to care for children who need developmental and behavioral pediatric services, as well as mental health services in the San Fernando and Santa Clarita valleys. So we wanted to develop a new telehealth-based system of care that could improve parent access to specialty care, increase the convenience of care, and then enhance measures of quality, including family-centeredness, timeliness, and care coordination. And then ultimately, we wanted to improve child developmental behavioral and mental health outcomes. So the telehealth platform, as you can see in this picture, is basically using a webcam and a computer to have families be able to connect with a specialty provider at a long distance. So the telehealth department at UCLA had already developed the technology of the telehealth to connect patients and providers. The telehealth, though, is not just for connecting people in rural areas. It can improve access for underserved urban communities as well. So this is a 3-year project. We're now a year and a half in, so compared to the previous presenters, we're just babies. And it's funded by PCORI as well as the California Community Foundation. Northeast Valley Health Corporation is a Joint Commission accredited, federally qualified community health center that has been providing care to the underserved communities of the San Fernando and Santa Clarita Valleys since 1973. Over 60,000 patients call Northeast Valley's 14 medical sites their medical home, and our 14 WIC centers serve over 70,000 women, infants, and children. So after we obtained the funding from PCORI, we started doing some stakeholder interviews and found that, UCLA found that Northeast Valley already had partnerships with a couple of mental health agencies in the San Fernando and Santa Clarita Valleys. So one of them is the Child and Family Guidance Center, which provides mental health services in the San Fernando area. Northeast Valley had recently developed a contract with the Child and Family Guidance Center, allowing for a social worker to be co-located at one of our health centers. In addition, for the same reasons, the Child and Family Center, similar name but not at all related, was added to the partnership. So this organization provides mental health services in the Santa Clarita area and also has a therapist co-located at one of our health centers. And then for the developmental behavioral pediatrics component, the concept of using telehealth technology to increase access for developmental behavioral pediatrics was actually initially brought to UCLA by Dr. Neil Soers, who had piloted this successfully in Kentucky. But as we were working through the process during our first year, Dr. Soers left UCLA. And so UCLA contracted with Children's Hospital Los Angeles to provide the developmental behavioral services for UCLA patients. And one of these physicians is also serving as the telehealth DBP specialist for our Northeast Valley patients in this project. So this is an overview of our process. In year 1, which was the developmental phase, we conducted stakeholder interviews with providers in the mental health realm and as well as the primary care realm, administrators, staff members, and most importantly, parents of kids who had already gone through the process to try to learn more about the challenges and the various ways that the project might be able to help. Also, a project working group was put together that includes participants who are primary care providers, referral coordinators, clinic administrators from Northeast Valley, the mental health clinic providers, therapists, and staff, and parents who have been through the process. And the groups have been holding monthly meetings to develop the intervention. Year 2, which we're right now in the middle of, is implementation. So we are starting to coordinate some telehealth visits. We're monitoring and adjusting the system slowly, and we are starting soon to do evaluation in a cluster randomized control trial that Dr. Coker will explain. And in year 3, we will do additional implementation, of course, as well as evaluation through data collection and disseminating results. So here are the components of the telehealth system. The meat is in the middle, the real-time video conference patient visits. Our audience is the 5 to 12-year-olds. And these video conference visits allow patients and families to meet with the specialist from the familiar comfort of their Northeast Valley Health Center. On the left side, you see enhanced clinician communication and patient coordination. So these are case-based sessions for patient handoffs. as the LA County Department of Mental Health policies changed, we found that patients who were receiving medication management only and no longer needing therapy are no longer eligible for services with their psychiatrist. So primary care providers are being asked to take over those patients, but they're feeling a bit ill-prepared. So the case-based video conferences that you see on the left are a mechanism that allow face-to-face handoffs and an opportunity for the primary care providers to ask questions before accepting the transfer. And then on the right side, you can see clinical education sessions. So these are topic-based sessions that allow mental health specialists to teach primary care providers about mental health topics such as ADHD, depression, and anxiety. So Dr. Coker will be next.
Okay, good morning, and thank you, Christine. So this intervention, I'll say, my job is to go through the details of how it came about. When we first applied for that funding, we had no idea that it was going to look like this. So I think one thing that I'll start off by saying is for the funding agencies to trust kind of the applicants that, you know, we don't know what we're doing, but we promise it's going to be really cool when we finish. And so that's kind of, I think, one of the things that we discovered. There's no way sitting at the table, you know, talking about between Christine and I what it's going to look like that we knew it was going to look like this. First, we didn't have all the partners at the time, so the two mental health, DMH contracted mental health clinics came on board. But just getting everybody in the room over multiple meetings, I think we really were able to come up with it. So I'm going to focus a little bit on really what the impact of having all the partners at the table had on the end intervention that was developed. And the things I'll focus on are these are the things that came out of the project working group. So after we did the stakeholder interviews, we put together a project working group, as Christine alluded to. And this working group met monthly over a little bit over a year. We were supposed to stop the monthly meetings at 12 months, but we kept going a couple months after that. And so the things that came out that really were important to address in the intervention that I'm pretty sure were not in the funding application at all were initial access for patients to mental health. I'll talk about what that means. Primary care support. And we spent a lot of time talking about the carve-out and what that means for the primary care providers. Transfer cases, which was a really big deal, and it took us several meetings to kind of get to the meat of that. The parents' involvement really brought into this family advocate telehealth care coordinator role that became part of the intervention, and then even the evaluation design is not what we thought from the very beginning. So this is I'm going to really focus mostly this morning on the mental health referral process rather than developmental behavioral, just because it's more complicated. So the primary care provider at the top at Northeast Valley makes a referral, and there's an initial connection to the DMH contracted mental health clinic partner. Then the mental health clinic gets the referral sheet, and within about 2 weeks, they make the initial call to the family to set up, to do the eligibility screening over the phone, and then set up a time for them to come in person to do their first intake visit. After that intake visit, they might receive a therapy or a behavioral health program that lasts several weeks. At any point during that time, they may have an internal referral to the psychiatrist for a medication evaluation, and then they'll continue with the psychiatrist for management. And then, as Christine's already said, at a certain point, the kid is doing great, they're taking their medications, they're doing well in school, their behavior has improved, and my goodness, it's time to go back to the primary care provider for management. And so that's the transfer, which I'll talk about in a minute too. So these are the areas in red, these red stop signs that really were identified by our project working group as a problem that needed to be addressed specifically as part of the intervention. So the first step was this connection, the very initial connection. So the primary care provider is making the referral, the parents listening and going, okay, you're referring me to a Child and Family Guidance Center, and you're telling me I'm going to get a call in a few weeks. All right, got it. So that first interaction was one of the first places where parents just fell off. And this was noticed mostly by the parent representatives that we had in the room and the mental health care providers, particularly the therapists noticed this. So they weren't familiar with the mental health clinic. When you're told you're going to be asked to go to a mental health clinic, that sounds weird to some parents. They didn't understand what services they provided. Sometimes the therapist even told us that, the parent, when they finally came into their clinic, oh, this is really nice, like they thought they were going to jail or something like that. So they didn't know what it was. The second stop sign here is this connection. So the mental health clinic gets the referral sheet, and then their job, the case manager calls a parent and has to do this 20-minute eligibility screening over the phone. Parents are getting a cold call. They're not even sure, right? They don't even know what the mental health clinic is. They're getting a cold call from somebody they can't see, and they don't know, asking them about what's your social security number, how much money did your family make, what's your child's behavior problem in school. So that was problematic from the parent's perspective and the mental health clinic's perspective as well. And then once they get into services at the DMH contracted clinics, they did pretty well. That wasn't the problem. So all that those green arrows, they're doing good. And then the next issue, stop sign, was really at that transfer. And the big issue there was really on both sides, primary care and mental health. The communication wasn't there to really provide support for the primary care providers in taking these kids on. Some, 1 to 2 medications, although they're doing well, there are a lot of problems around, well, let's say they're doing well now and they have a crisis, or something bad happens in their family and the depressed kid who was doing really well suddenly is really depressed again. Or maybe they're going through psychosis. I'm a general pediatrician. I am a general pediatrician, and I don't know that I'd want to take that on. So I think that's some of the things that was going on at Northeast Valley. So the intervention is specifically designed to address the issues that came up in the project working group around these issues. So the first yellow star is the parents really, I think, brought this up, and we spent a lot of time in the project working group trying to figure out, okay, how are we going to solve this issue of parents not wanting to actually say, okay, I'm willing to do the mental health clinic. And one of the parents said, look, what about giving us a video so we can see what these people look like, and we can meet them ahead of time, and they can explain what they do. So we did it. And so this is a video orientation. At the time of the visit, the doctor is telling the parent about the mental health problem and the referral to the mental health clinic. Then after that, they see a 5-minute video that actually has, and we just finished one of the clinics, and the other one is under editing. We actually have a script and everything. It was an interesting process. But they actually see the people who are going to be working with them. They hear about the process. They see their faces. The next yellow star here is that cold call. So the parents did not like receiving the cold call, and actually the case managers didn't like doing it because it was, well, one thing I didn't talk about was the phone numbers changing. So within 2 weeks, they had a new cell phone. That wasn't easy to get to them. So for this, we created to do this whole process via telehealth. The parent wanted to see who's on the other line. What do they look like? And when they go, so if it's the telehealth screening happens on a Friday, so that any referral that's made on Mondays through Fridays, really, as long as it's before the screening time, you go that same week. You come back on Friday. If you're referred on a Monday, you sit with the telehealth care coordinator or family advocate at Northeast Valley. So you have a trusting person. You go back to your primary care clinic, and you're looking at the folks from the mental health clinic in the face, doing the paperwork right there with your care coordinator. So that is to solve that issue. And then the transfer, really, Christine talked a lot about sort of the collaboration that's designed to address a lot of the transfer issues. So to do a little bit more detail, the educational webinars are those kind of topic-based seminars that are once a month. We have a schedule of seminars focused on the most common items that are going to be discussed, or most common diagnoses that Northeast Valley is seeing. Case-based transfer sessions. So as a psychiatrist, if I had a patient who is stable and I think is ready for transfer back to the primary care provider, I identify that primary care provider. I take one of our weekly Monday kind of slots, and the other primary care providers at Northeast Valley can join in, but we spend some time via the video conference really talking about who the patient is, what are the medications they're on, what are the side effects to be looking for, how do you monitor the patient, how often do you monitor the patient, when do you need to come back to us, that kind of thing, to just bring that comfort. The second part of comfort comes in the fact that these sessions are scheduled on a weekly basis, so that if I'm one of the primary care providers that's taking the responsibility for this patient, I know that I'm going to see the psychiatrist again in the next week, so I can ask my question. We'll do weekly mini rounds during these sessions. So on the shared patients, they discuss the patients that are shared, so that once you take the patient on, it's not like I'm done. Nope, you've got support through that. And then the family advocate role was really important from, I think, all the stakeholders in the room. Having somebody who is able to work with the parent. Parents didn't always like having to contact the psychiatrist or even their pediatrician for little things. And little things are like, how are you doing on the new medication we just started? So they felt comfortable having a care coordinator or a family advocate in that role to help. One thing I didn't talk about, and I'll just say quickly for the telehealth collaboration, is the issue with a carve-out really for primary care providers now being responsible for the mild cases, the moderate cases being at the health plan, behavioral health plan level, and then the severe cases being at the DMH payment level. I think it was good timing, because it's something that both from the primary care perspective and from the mental health clinics, that, you know, we're going to have to be taking care of some of these patients when they're mild, whether or not they're on one or two medications. So, and then just 1 minute, because that's what I have left, on evaluation design. So the really interesting thing I kind of alluded to about the design. So when we applied for funding, it was an individualized, randomized controlled trial. And it became apparent in the project working group meetings that we were going to be asking parents at the same time they got their initial diagnosis that their child has a mental health concern and needs a mental health clinic. Oh, and by the way, would you be a part of this study? So because of that, we kind of talked through the process, and we came up with, well, maybe we should do a cluster RCT so that the clinics are randomized rather than the individuals. We were lucky. We went back to PCORI. I was a little nervous when I was going to tell them that we wanted to change the design, but the great thing about, I think, being funded by an organization or an agency that's focused on patient-centeredness is that they kind of knew it before I even asked, so it was great. So we're doing a cluster RCT. My time is up. I won't talk about the outcome variables yet because we're starting enrollment like next week. But our main outcome is access. And that's it. Thank you.
Well, thank you to each of you for some very interesting work. I think all three of you clearly articulated this work cannot be done alone, that these types of partnerships are truly necessary to be successful, and I'm sure there's some questions in the audience. So we have about 10 to 15 minutes for questions, and there's some microphones that can come to you. So if people have questions, raise your hand, and someone will come to you.
Thank you, everybody. Good morning. Great presentation. My name is Hector Ramirez. I'm with the Mental Health Services and Oversight Commission. And I think I really, really appreciate the work that you do, especially in evaluating the programs and being able to make sure that for us stakeholders, as we're paying, that we're actually getting some, valid work that is going to be working instead of just wasting our money. I really like the approach that this particular, that Pacific Clinics and the collaborative is taking. I think at the state level, we're looking for ways to be able to evaluate the effectiveness of those programs. How could you utilize these approaches that you're taking to the state level to ensure that our mental health services or our medical services, as they're being integrated, are actually providing with the necessary deliverables? I mean, I think that MHSA or some of our stakeholders really would love to be able to fund some of this evaluation process, to be able to make sure that the programs that we're funding are actually working, so we don't have other questionable outcomes.
So, oh,
Is this on or? I think so.
John?
No, here, come up.
Doesn't sound like it's on, but I
No,
guess
it
it's on. Not on.
You can come up here.
I'll come up
Done?
So one of the interesting things about this practice-based research network is that we have to start in a very, as I mentioned earlier, kind of a rudimentary way. From a research perspective, using only client self-reports for these kinds of outcomes. But one of the things that we'd like to do as we evolve is include more agencies and move to other kinds of outcomes as well, such as administrative outcomes or perhaps even Medicaid outcomes, where we can look at things like client utilization of services from integrated care from multiple kind of data perspectives. So that's the kind of thing we're hoping to evolve towards in this PBRN. Now, we have 5 agencies involved now, and we're kind of at the point where we're seeing how deeply this roots. It is rooted very well with these 4 agencies. And I think as we expand, because it is so participatory, that we, like many of the presentations here, you see this real community excitement, however you're defining your community, to be involved in these kind of projects. So how to ensure that these kinds of things grow and get to the kind of answers that you want is one of the things that we're involved in seeing ourselves as how we can move to greater scale. You're talking about moving to scale, and that is a challenge, one that we're hopefully ready to take on. So, Laura, did you want to add anything to that?
I think that it's been really nice to be able to go to stakeholder groups and say, yes, this works, because I've been involved in so many MHSA groups and stakeholder groups, and so it was a nice, simple process, and I hope that we can expand it. That would be great. A lot of RFPs come out, and people are asked to come up with their own evaluation, and there's no guidance on how that should be done. The outcomes are there, but not really how it should be done. And so, having been involved in many different types of research and outcome projects and studies, this was so simple and easy. And the best was, as John said, we had so much participation from the consumers because of the way that it was rolled out. And I think that's really important, because I see that sometimes the loudest voices get the most attention through the MHSA process, and sometimes we're not hitting the bigger crowds to get their feedback. So it was nice. We got a lot of voices were heard in terms of, did this work or not? Yeah, so.
Any other questions? Okay, and then in the back after. Yeah, the blue jacket.
Just to sort of continue to follow up on this, and I saw the first 2 groups address this issue that's very common. Research funding pays for certain things, and it doesn't pay for other things, right? And then practitioners can get paid to do their work through Medi-Cal or whatever. And so when you have a research practice partnership going on, you would hope that all of the gaps could be filled with, well, the research people will put their money in, the practice people will scramble and figure out how they can get paid for their piece. But there are always holes. Every single project I've ever worked on, there are always holes. And I think as a group, we need to gather and say, where are those holes? Those things that don't get funded by either source, or you have a gap a whole year where you can't find any funding. And where is the entity, the funding agency, that wants to fund that? And I think it would be so hugely beneficial, and I would wonder if anybody would want to comment on that.
So I think this is on. So I think that's a great question, and funding is kind of always on the mind. But when so the PCORI funding, I think one of the holes that we had was when we knew what the intervention was, we said, oh, we need a telehealth care coordinator. That was going to be a kind of a bigger role than we had envisioned in the beginning. And we wanted that person to be internal to the organizations, so internal to Northeast Valley, internal to Child and Family Guidance. And we did not have that funding with our subcontract because they were kind of already done with the first grant. But then we got funding from the California Community Foundation. And it was kind of a, I'm not going to say random, but you know, it came out of nowhere, right? When we need, yeah. So I don't know how to, but so that was, you know, it's a smaller foundation funding when we look at kind of just the funding amount is much smaller than the PCORI funding, but it allowed us to add something that we didn't know we needed that was going to definitely be a hole. We wanted, we don't want any of the partners to have to eat the cost and say, well, you know. So that really helped a lot. There weren't a lot of strings attached, and so I think once you have some large funding, maybe somehow getting smaller pieces here and there for the things that you didn't anticipate.
We have a lot of gaps, and it varies from agency to agency. So some agencies do have funding that supports them training their therapists in our new technique, where others, such as mine and other smaller agencies, don't. So we have to look like you did for the smaller funding by individual agency instead of the full project.
Yeah.
So great projects, all three. I'm wondering, in the collaborative process, and this was alluded to in a couple of the talks, the role of leadership, different leaders at different levels, you know, at the consumer level, at the agency level, and researchers. It's not talked about to a great extent how that really plays out and how some of those differences are resolved, although I think Dr. Stahmer, you talked a little bit about bringing an outside person in to help the egalitarian process, but I wonder if from each of the projects or you have any observations on how that plays out and how leaders take on roles and work together through that process.
I think it's on now.
Oh, it does work now. Well, we're actually going through a leadership change at the moment. As Laura mentioned, we began with an individual in the community who was with D.D. Hirsch Mental Health Agency, and this was his brainchild. And the CTSI provided us the first funding for this PBRN. And his leadership, as Laura mentioned, was very important because people immediately in the mental health community trusted him and knew that he wasn't going to waste people's time. And so that leadership was incredibly important at the beginning. And then we went through some leadership challenges because he moved to Colorado, and then another person took over from the community. She also moved then to Northern California, and we have yet the third leader. Now, the thing that has actually, and Laura, I'd be interested to see how you respond to this, but there was tremendous cohesion that developed in this PBRN because of the participatory process. That, in my opinion, is what has allowed it to survive these leadership changes. And we now have a new leader who's just taken over, and it's amazing how well people have stayed committed to this. And I think it's that participatory process that really cemented it with the consumers and the providers, and how that process bore out and was real. Because these kinds of leadership changes can be devastating to a group like this that has so many gaps. And we're also living those gaps now. We have a funding request out now that kind of says, so we have two types of needs: infrastructure needs and project needs. Where do you want to fit?
Yes, the participatory process laid the foundation, and then actually the change in leadership helped us, I think, take more ownership, because we knew if we didn't step up in some ways, it would fall apart. So now I think we're even more invested and more committed and excited about the new leader, but it also is important to have a very clear leadership. And I liked what Aubyn said about, can you just bring the bagels and set up the meeting? I mean, that's the type of work, that's the pieces that we need. Really, it comes down to that. And then we like to think and talk and give our ideas and everything. But yeah, so I think we're in a good place with this new leader because we're also invested and committed.
Okay, there's a question over here.
Yes, hi. I guess this question could apply to the bridge and the telehealth. Sometimes mental health referrals don't happen because of lack of insurance and things like that. Did you have that problem with eligibility? And if so, what did you do?
Yeah, we've had that problem, and we've worked with our public. The age of the children that we are seeing is Part C eligible. So we worked with our local regional center, who was part of our collaborative from the very beginning, because we knew that was who was going to be most likely doing most of the funding. Of course, we started before insurance would cover autism, so it may change. But that's how we've covered a majority of the funding. And I think we have a really great champion, and now two actually on our collaborative from that funding agency, and they have kind of pushed this through, and because we've got data to support it, it has been able to stay so far, but having them on our team has been what got us funded. And you agree?
And we have to keep going back to those funding sources, to the unit meetings, and reintroduce the concept to them, because they seem to forget from one month to the next that we're there with this new innovative programming, but we have to be really visible.
So I think for us, the main, on the mental health side, since we had the partners at the table who were DMH contracted, that the insurance wasn't an issue there. But the bigger issue is with developmental and behavioral pediatric consultations. And I think, part of it is availability of those providers that take Medicaid. That's one piece. And then the second piece is getting it approved by the insurance companies so that it gets approved for them to actually go.
Yeah, absolutely. So going back to your question about having leadership involved, one of the reasons that we were able to move this project forward with the leaders above me was convincing them of the need for the services. So just like Tumaini mentioned, the project came at a great time because we were finding that DMH rules had changed, and primary care was going to need to accept back some of these transfer patients that we weren't ready for. So we needed to have the communication with the DMH providers. And also, our DBP provider, we are in the Valley. The DBP provider that is contracted through the RIPA is in Long Beach. And so families have been having quite a bit of difficulty getting transportation all the way down there for an excellent referral and consultation. However, it just takes them so long to get there. And so our leadership found that this was a need and really moved forward with okaying the project.
We have time for one more question over here.
Good morning. I want to know, have any of you thought about, or maybe I missed it, of getting community involved? I heard you say community, but they're all agencies. But have you had community participation? People that live in that community to tell you what their personal needs are, or did you just rely on those agencies?
We have parents in our collaborative from the community, and we also bring in, when we were choosing the intervention, we brought a wider range of families.
So we had the families all meet with us at first to tell us what they were looking for in an intervention.
Yeah, and we have had the same thing. We've had stakeholder interviews with parents whose kids have gone through the process, and we have at least 3 or 4 parents involved in our monthly project working group meetings.
One thing that's helped, I think, with the project working group meetings and the parents' involvement is that from the very beginning, because I think it's hard for parents to feel like they're on an equal footing sometimes with when their own providers are in the room, or just with physicians. So we kind of set up from the kind of like ground rules and the first meeting, project working group meetings. We try really hard to do first name basis only, so it's not doctor this, doctor that. We actually have some parents who aren't fluent in English, and so they have, we kind of use the UN model, someone's in the ear doing the whole translation, and so they're able to contribute. So they're really integrated in the project working group, and there's really not a distinction when we are making decisions, and there's a lot of times in these meetings where we're stuck, and the groups or agencies, we can't make we can agree on something, and sometimes the parent will offer a sort of in between, and it takes that voice to kind of have everybody listen up.
One of the reasons I ask that is because you might think about, and maybe you have, when you write your budget, include them when you're doing your proposal, you're writing your whole documentation, and also compensate them. You guys get paid for what you're doing, but then community doesn't, most of the time, are not compensated for that.
Couldn't agree with you more. And on our project working group, whether you're a physician, a psychiatrist, or a parent, you get the same amount, same honorarium.
Wonderful.
Yeah, same with ours.
Thank you.
Okay, since you were so enthusiastic, one more.
Good morning. Good morning, and thank you. My name is Reba Stevenson. I'm a consumer with Department of Mental Health Service, so I receive services. I want to say thank you to each and every one of you, but I also wanted to acknowledge Dr. Brekke for the Health Navigators training, and I am a certified Health Navigator. Yay. And yay! So here's the deal. I'm thinking about you a lot lately with this change that's happening with the collaborative changes through the departments merging, or however we want to put it. And what I'm realizing is why it is so important for us, people like myself, to be heavily involved. Why? Because we actually receive these services. The one thing that I can compliment about health navigation is that it involved people like myself to actually engage with someone like myself that actually understands what like myself is experiencing. And it has to be across the board, and the reason why it is because we have something that perhaps you really don't have, and something in which you will never have. And that is to be able to actually engage and connect with someone based on the fact that we have had similar experiences. Each one really should teach one. And it saddens me sometimes when I think, too, about when we are doing research and all of these numbers and these graphs, and people like myself are missing. Because we really are a missing link to a lot of the researches in which you're doing. As Dr. Brekke has done with health navigating training, I mean, it was just simply amazing. I use it everywhere I go. Here's what's fascinating about being involved. Allowing someone like myself and my peers to be involved not only allows us to be engaged in whatever the training itself is, it actually says I go home to my son, or I go home in the community, wherever I am, and I'm actually being able to practice this because it works. And it works even if it's not a person like myself. You understand what I'm saying? So I am encouraging that everyone really take a look at what it is that we have to offer. When we talk about what's about to happen here in this, with this merge through the Board of Supervisors and how all this is coming down, I am greatly affected by this. And what happens is that if it's not people like me who talk to people like you, to support people like you in making this thing work for all of us. It is just truly, truly vital. And so thank you. I hope you understand where I'm coming from. I have a great concern. And I think that we need to tell everybody who you are providing the services to that they too need to be sitting in rooms like this with their concerns. Thank you.
I want to thank our presenters one more time, and I think now we are going to a break, and there will be posters up for you to meet with some of the other researchers and collaborators that are working in this area. So we'll adjourn until 10:30.
I could steal just one more minute of your break before you head out, give you some brief orientation to what happens after the break, because it's a good 2.5 hours before we see you in this room again. My name is Brian Mittman, a member of the Planning Committee. So you're about to go into the third component of our 5-component meeting, and that is posters. You'll have an opportunity for the next 25 minutes or so, as well as during lunch, to see the posters and for informal interaction. One of the goals to achieve the objective and the mission that you so nicely outlined is for you to create partnerships. The fourth component of the meeting will be at 10:30. You have in your program a set of what we call skill building sessions. Those were a direct response, as Moira said, to the evaluations from last year. An opportunity for you to learn a little bit about some of the research skills, some of the practice skills, how to go about developing partnerships, to conduct community-oriented, partner-oriented research. After that, lunchtime, and after lunch, back in this room at 12:30. We have a tight schedule, especially in the afternoon. We'd like you to keep an eye on the clock, and we look forward to seeing you after lunch.